Since you mentioned first-line treatment, let's just go ahead and talk about first-line treatment. Explain your approach to first-line treatment with steroids. What course do you use? What drugs do you use? How often are you treating, and how do you taper?
Yeah, so the first-line patient, once I decide that the patient requires therapy because of bleeding symptomatology, their platelet count has dropped rapidly and below a certain threshold that I am using in my own clinical practice, then my own approach is to consider either pulse-dose dexamethasone or prednisone. My own preference is pulse-dose dexamethasone, 4 days of dexamethasone, and like Ralph was also saying about the potential for rapid response, durable response, and arguably a slightly higher response rate than the more traditional lower dose 1 milligram per kilogram daily of oral prednisone. So those are the two primary options I'll consider and I think are reasonable for any hematologist to use in practice. My own preference is the pulse-dose dexamethasone. Primarily, my decision for that preference is driven by slightly higher suggestion of response rate and also the very short course of therapy where prednisone, of course, is notorious for the many side effects and often to the point of tapering when you are using oral prednisone, 1 milligram per kilogram as a starting dose daily, then it can often take several weeks to taper, and even then it may not be a smooth process, as we know, because we may go below a certain threshold and they start having their platelets go down again. Right. And then you have a situation where you may have to increase the dose again, so it may be a bumpy road as you try to taper the oral prednisone. So because of all those reasons, I feel that the pulse-dose dexamethasone is perhaps a little bit more in favor, in my opinion, but either can be considered. The society guidelines, like the ASH guidelines, say that you could use either or as reasonable options, so I think a clinician could consider it. The other things that are potentially things that we might think about would be, do we also need to incorporate IVIG, intravenous immunoglobulin therapy? That usually will be reserved for somebody who has a more acute type of situation, inpatient, significant bleeding, surgery about to be needed, something of that nature where we need a rapid increase in the platelet count. And there is data, randomized data showing that prednisone plus IVIG is superior to using prednisone plus high-dose steroids like methylprednisolone, for example. So because we do have some data to inform us to say prednisone plus intravenous immunoglobulin can be advantageous to rapidly boost the platelet count, and often clinically that will mean that even by the next morning after starting the intravenous immunoglobulin, you should see a bump up. The patient who started, let's say hypothetically, at a 3,000 platelet count, the next morning is 21,000. And may not be quite ready for the surgical operation yet, but at least they're making their way up, where often within 3 to 5 days clinically we'll see the platelet count rise to a more acceptable level for surgical operations, 50,000, 70,000 or something higher than that.
Would you ever use, or have you ever used another combination, for example, Promacta in the frontline setting with steroids?
Yeah, so I have not used that personally. There is data that was presented initially at last year's ASH conference 2018, and in that meeting they had some data about giving end plate with steroids up front, as well as a separate small study giving eltrombopag with steroids up front. So these were not randomized studies. They didn't have long-term outcome endpoints.
Yeah, certainly not a standard approach, but I just wondered what your...
Right. I mean, I think the line, so to speak, is that it's not quite ready for prime time, but so I wouldn't use that currently in practice, but at least it's being explored where maybe that may be utilized in the future. I would just say not quite right now in the setting of very small studies that we have, showing us some evidence for benefit, and of course not randomized data.
And we might just mention that the new ASH guidelines specifically do state that they do not recommend that type of combination therapy be given in the front line.
Mm-hmm. Although Arnold just published the Canadian study, which suggests that eltrombopag, in a patient who's not otherwise being treated, who needs to have surgery, 3 weeks of eltrombopag was actually superior to IVIG in order to get somebody ready for surgery. So we have other options.
Yeah, so that's not the frontline therapy, but in the preoperative setting, absolutely, excellent.
Which may be the first time a patient needs to be treated.
That's true. You're right. Yeah. So just before we move on from combinations, so we we are discussing the data that's out there. We know it's not ready for prime time. It's not in line with current guidelines to do a combination up front, but I just want to see if there are any other studies that you have seen of upfront combinations, because how are we going to improve outcomes in these patients? You know, we have good therapies for second line and refractory settings, but an upfront, more robust treatment strategy might elicit longer duration of disease remission.
Well, it brings up an interesting topic, and that interesting topic is, are we potentially better able to cure patients if we manage them in the front line in a different way?
I didn't want to say the word cure, but I'm glad you did.
Put them into remission, let's put it that way. And it's kind of funny the way that remissions are defined by, at least the ASH guidelines, it's 100,000. So I think we can all agree that that is a more than acceptable level. But I mean, mycophenolate has been used now with corticosteroids. It has already mentioned rimiplostim and L-trombopeg with corticosteroids. So it's a topic that's hot right now because we're looking at earlier therapies and combination therapies with the specific notion that we would like to see whether or not, if we do that, we can change the natural history of this disease.
Because we do believe that the longer somebody has this disease, if you will, the more dug in that disorder becomes. There's more epitope spread, they become more and more difficult to treat. And it may be that we want to treat them hard up front. But I think we need more data for that.
So last thing about frontline therapy, because this is probably the only time that we'll be discussing steroids, we're going to move on to other therapies that are seen in the second line refractory setting. But just for completion's sake, Rick, can you just talk about the side effects that steroids give, how patients feel taking them, and also if you want to comment on whether you do use separate courses of steroids in the refractory setting?
So good question. So as Terry brought up earlier, so patients, if they've been exposed, they know what their side effects are, and that really leads to them being wanting to look to anything else for their treatment options. So concerns, of course, we're going to be worried about blood sugars, inducing diabetes, hypertension. We're going to be concerned about CNS effects. So you're going to have changes in depression or inability to sleep, a lot of the things that really drive people crazy, feeling jittery, feeling agitated. And so each of those are their own individual concern. And then to your question on whether you would retreat, and to take one step back, I do favor slightly the dexamethasone option as well up front. And in certain cases, if you are 14 days, 21 days down the line and you have a situation where count is very low, other symptomatology, I might repeat it in that situation. I will not sort of indefinitely repeat steroid, feeling like that's going to have less and less benefit.
And we have other things now.
And we have other options available down the line.